And Srinivas Joshi needs no introduction, an extremely versatile, amazing vitreoretinal surgeon and a member ARC South, and literally a right hand for me in my ARC ventures. And I'm sure he has a great future ahead, and he's going to be talking to us on current concepts in prevention and treatment of CME. On to you, Srinivas.
Thank you, madam. Thank you so much. And as always, you have been very supportive, and all ARC members, we are very thankful to you. I once again welcome all the expert panel and the speakers for this ARC program. Thank you, Chitra madam, for giving this opportunity. And I request pardon from Samaresh for just skipping by one speaker. Sorry, Samaresh. So I'll be speaking on the current concepts in the prevention and management of CME. So this is the case one, 65-year-old male, complains of diminution of vision in the right eye since 10 days. So he's a diabetic, 5 years on oral hypoglycemics, both eye cataract surgery done 2 months ago. And left eye, if you see 6/6 vision, and both eye quite pseudophakia. So when we look into the fundus features, it was featureless. It was absolutely, there was no findings. But however, if you see very carefully here, there was a little dull FR. As compared to the left eye, when OCT was done, definitely you can see the cyst. In which layer? I will come to it a little later. So this is the another case, 55-year-old male on diabetes since 15 years. After the surgery, the patient complains of blurring of vision. Again, if you see the same eye which was operated. Now, when you see the clinical picture, not much, but definitely when you look into the 78D or 98D, it's very hard to miss the minutest micro aneurysms which are seen in this area. And when we look into the OCT, definitely you can see some cysts and you can see some microaneurysms and the hard exudate. So differentiation between the two, we'll come to it a little later. So what's the etiology for the CME? It can be vascular, it can be a diabetic macular edema, vein occlusion, or hypertensive retinopathy, or it could be a PCME, what we call it as a Irwin-Gass syndrome. Or it could be an inflammatory conditions, retinal dystrophies like golden fiber syndrome, drug-induced, sometimes the glitazones itself, where the patients keep using for the oral hypoglycemia, that itself might cause the macular edema, prostaglandin analogs, and definitely the tractional component is the ERM, VMT, and the FTMH. So most common causes are the diabetic macular edema and the pseudophakic macular edema, what I described as a PCME. So we all know that the DME characteristically accumulates in the outer nuclear layers, that is in the ONL, and the Henle's layer rather than the fluid in the innermost layer. What about it? I'll come to it a little later. So what about the factors associated with increased risk of PCME? It could be various ocular conditions like vascular diseases, diabetes, CNVM, certain drugs, certain retinal dystrophies, retinal detachment, optic nerve head abnormalities, including optic pit, optic nerve coloboma, vitreous surgery, laser, they all might cause increase in the PCME. Surgery, we all know that additional trauma, especially handling of the iris or posterocapsular rupture, vitreous loss, vitreous traction, and high phaco energy, especially and also during the long duration of the surgery, are associated with increased risk for PCME. Now, this is the ETDRS grid, which I have shown here. So basically, if you see the Irwin-Gass and uveitic CME, they both are very similar as on the OCT picture. But if you look into the mechanism, Irwin-Gass is because mainly with the prostaglandins, and uveitic CME, say, I'm not talking about the dense vitritis where it's very obvious and we can definitely diagnose it. But in grade 1 vitritis, when there are trace cells, but patient having an intermediate uveitis, so these are the patients who usually they have a T cell cytokines or the CD4 cell immunomodulation. So when we look into the ETDRS subgrids, say 1 mm, 3 mm circle and 6 mm circle. So this is how ETDRS has described the macular edema in these various common differential diagnoses. So if you look into the CRVO, in almost all the subgrids, subset of these grids usually have the cysts. But whereas the important for us is mainly uveitic CME and Irwin-Gass. Irwin-Gass is mainly to the central subgrid only, whereas uveitic CME might extend to the outer circle. However, BRVO, we know superior temporal, they have a cone shaped either superior. If it's infratemporal, they have cone shaped either the inferior. So now if given this diagram, so how we can say that what is what? Definitely this one, if you see the top, the first one, you see the cysts are in the outer nuclear layer. And along with that, you see some HRF, what we call hyperreflective foci. So these are basically seen most commonly in the diabetic macular edema. That is, it might have an adjuvant hard exudates as well. Now, the next important for me is to see from C to E, because which is pretty much similar. But for me, the FE looks similar because it is symmetrically, if you see, it's a symmetrical type of macular edema on both the sides. It's a center involving. The cysts are mainly in the INL layer. Later on, it might go into the ONL, but definitely there is absence of foci in these areas. And this, if you see, this is a uveitic CME. So it is a slightly broader as compared to the PCME, that is pseudophakic macular edema. So what's the main difference between DME and pseudophakic CME? I think just in the last week, Titiyal sir was asking this question. Is the macular edema pattern? The DME has the diffuse or the focal, whereas pseudophakic CME is very much central. And location of the cyst, usually it is ONL and HNL Henle's layer in case of DME, whereas it is mainly INL in case of pseudophakic CME. And most importantly, you should know this presence of this hard exudates or the foci and all those things. Hard exudates usually cast a shadow. That is why we call it as a hard exudates. But whereas this has not casted a shadow, which is a precursor of the hard exudates, which we described as a hyperreflective foci. And however, the hyperreflectivity lines of the outer retina is usually disrupted in DME, but they are usually preserved in case of CME. So this is again another picture. If you can see here, you can see this hard exudates casting a shadow here. These are the multiple hyperreflective foci or the dots which are not casting. The cystoid spaces are mainly in the ONL. But here, if you see, in case of CME here, you can see definitely there is a subfoveal fluid and the fluid mainly in the INL, but in turn, they might go into the ONL as well. So what are the treatment, what we have? We have NSAIDs, we have corticosteroids, anti-VEGF, carbonic anhydrase inhibitors, and definitely pharmacovitreolysis. So role of ocular steroids, we all know very well, stabilize the blood retinal barrier, downregulate the VEGF, and inhibit the production of prostaglandins and the pro-inflammatory cytokines. So this is very important, we need to know. We all know that corticosteroid basically inhibits the phospholipase A2, which goes in, gives up the arachidonic acid. This goes into the leukotriene cycle. This goes into the cyclooxygenase cycle. So what is most important for us is the COX-2, which are abundantly found in the RPE. So we need to inhibit mainly the COX-2 inhibitors, which are mainly because of the NSAIDs. So currently there are different types of corticosteroid, but in India, most commonly used is the dexamethasone implant, and fluocinolone has not been available yet. But however, intravitreal triamcinolone can also be used as an intravitreal steroid injection. NSAIDs, we all, as I said earlier, it inhibits the cyclooxygenase enzyme that decrease the production of prostaglandin. There are different plethora of NSAIDs available in the market. But let's look into this paper by AAO, which says that we found high quality evidence that topical NSAIDs are more effective than topical steroids in preventing PCME. This is by AAO in 2014. Now let's look into this meta-analysis published in 2021. So the PubMed database for randomized controlled trials, since 2000, they have seen into various clinical trials, and they found out that clinical practice and theoretical background support topical non-steroidal anti-inflammatory drugs as the first-line therapy. Invasive procedures such as periocular steroids, intravitreal corticosteroids, and anti-VEGF are usually in the prolonged or the refractive cases of PCME. This is another study, comparison of efficacy of Dex, Nepafinac, and Bromfenac, and it has shown that not one drug alone, but combination of steroid with either Nepafinac or Bromfenac has shown to have a favorable outcomes. This is another study, comparison subtenon triamcinolone acetonide, which is my favorite, with the topical Nepafinac for the treatment. However, this study has shown that topical Nepafinac is more efficacious than subtenon in terms of visual gain and its correlation with reduction in central retinal thickness. So these are few of the pictures when they come to the retina clinic and when the intersegment surgeons refer, it could be a PCME. These are the pictures, very typical what we see of PCME. One shot of PST, you can see within just 1 week or 2 weeks, the patient will be fine. This is the another picture who has SFF, who have cystoid spaces, multiple cystoid spaces. Again, one shot of PST, it's gone. This is another picture, just showing you a few of the examples with the efficacy of the posterior subtenon's injections as well. So last slide, topical bromfenac reduces the multiple inflammatory cytokines as published in this, again, 2021, which they say that in the aqueous sample taken, they have shown that the platelet-derived growth factor, and when we compared it to the fluorometholone, they found out that bromfenac significantly decreases the VEGF factor as well as the monocyte chemoattractant protein, which was elevated for a long period after phacoemulsification. So these are few of the drugs, again, which has a little bit of controversy, which says that since it's a non-FDA approved drugs, do we have to use it? But last, I would like to say of this study, which is done in 2015, which says that although dosing of NSAIDs before surgery may accelerate visual recovery within the first several weeks after cataract surgery, but there is no level 1 evidence to support the long-term use of NSAIDs in preventing vision loss secondary to PCME after cataract surgery. So vitriolytic agents, and if there is a traction like this, if there is a VMT, vitreomacular traction, then definitely you can use either a pharmacolytic, or it's better to use a surgical option to remove the traction. Thank you very much for the patient listening. I would like to acknowledge Department of Vitreoretina and my fellow for picking up the cases for me, Dr. Rohan Dedia.
Wonderful talk, Srinivas. That was so enlightening and informative to all of us. I think first I would also like to welcome Dr. Sue Fekchi and Dr. Beva Savda. Though they joined late, I'm sure they're going to add to the discussion. I just have very basic questions. I would want more interesting questions with the expert panel. Srinivas, like supposing the first eye has had a CME, does it make sense in using a prophylactic pre-op NSAID earlier on in the other eye?
Yeah, it makes sense, madam. And most of the surgeons, we definitely use that. But when we look into any of these clinical evidences, there has not been any paper which says that, yes, using this preoperatively, it has a long-term effect, or not using this preoperatively has a long-term effect. But definitely when you look into the clinical evidence, the clinical acumen, and what response the patients are showing, many of the surgeons have given up, and they have said it in most of their case reports also, that they do use preoperatively and postoperatively at least for 1 month or 1.5 months.
More anecdotally, although all of us do start steroids and NSAIDs together, does it make sense that you use NSAIDs later, start off with the topical steroids? Theoretical discussion, would you want to add the NSAIDs later, or you feel both should start at the same time?
Madam, if you ask me, most of the papers have shown that it should be both complementing with each other. That is what many of the papers have shown. There's no. I tried to look into it, did a PubMed searching, but I couldn't find that definitely we need to start with steroid first and later on, because last slide which I showed has definitely shown that the NSAIDs has no long-term effect if you use it after 3 months. So basically it is because most of the time we have this between 4 weeks to 3 months. The CME usually happens between 4 weeks. It's peaking at the 6th week. So it makes sense to use this around that time, that is around from 1 month to 6 weeks, so that you don't have that peak of PCME.
A diabetic CME in one eye, for the other eye, would you think of changing the steroid drops, or what would be the topical steroid drop? Would you prefer, or there is no need to be specific on that?
Diabetic pathology, it's very much different, madam. If they have a DME, which I showed it in the OCT pictures, like if they have this hyperreflective foci, or some authors have even called it as a microfoci, if they have any hard exudates, if they have any microaneurysms, it very much indicates that it is a case of DME. And DME with topical will never go. It has to be treated intravitreally. And again, there are a lot of OCT biomarkers where we need to see which one fares better for steroids and which one fares better for anti-VEGF. Although the first line of treatment, when you know that it looks more like a DME because you see a small microaneurysm in the OCT, and beside that you see a small cyst basically in the outer nuclear layer. It gives you more confidence that it looks more like a DME. So that is when we switch to anti-VEGF. But if there are too many hyperreflective foci and very tall, large cystoid spaces, and in those cases, I think it's better to switch to intravitreal steroids.
Yes, Dr. Basavda, yes.
Yeah, I think the point you raised of the second eye is very important. And I want to caution operating the second eye too early. You can operate in a normal situation of 1 week, 2 weeks, or whatever, but the eyes which you are suspecting CME postoperatively, all the high risk factors, please wait for 3 to 4 weeks before you operate second eye. I had a very bad experience of doing on the second week of the second eye, and both the eyes developed on the third week of each post-operative cystoid macular edema. It was very embarrassing, and it took time, but I think if you're suspecting that this is a likely candidate, do all what you say, but do not operate the second eye until that 3 or 4 weeks time that Dr. Joshi mentioned is negotiated well. Thank you.
Yes. Any other thoughts before Srinivas moves out? Any other relevant question we want to ask about the CME and post-op patient satisfaction?
There could be instances where the CME and CSME could be coexistent. The patient already has a CSME, you have controlled it with your intravitreal steroids, then subsequently the patient comes in for a cataract surgery, and there is a flare-up post-cataract surgery. How will you manage these situations?
Very good question, sir. Actually,
what is CSME, DR? CSME? What is that?
That's a clinically significant macular edema. That's the ETDRS classification of
diabetic. Okay.
Okay, diabetic macular edema. It's a very good question, Ramurthy sir. In fact, the confusion happens when the patient is already a diabetic and he has a DME, and then we do a phacosurgery, then he has a CME, though the confounding factors present is between the PCME and the DME. So the first important point here is usually when there is a CSME, it's always better to first control the CSME, do an OCT. If it's a center involving, give the intravitreal anti-VEGF injections, and then you can go ahead with the phacosurgery. I have seen in certain instances where some authors, some surgeons prefer doing phaco as well as anti-VEGF in the same shot. Or if the OCT biomarkers show that it's a kind of chronic DME, then phaco foldable along with the intravitreal steroid, that is a DEX implant. So these are the things which can be done on the day, or it's always better to first try to treat the DME and then go in for the phacosurgery.
Yes. I think that's a very important, a lot of important messages came through, like OCT is a huge role play in our diagnosis and management. And thanks a lot, Srinivas. I hope you're able to combine and join.
Sure, madam. I'll come back. Yeah. Thank you.